when we were doing the original randomized metastatic trial, patients either got doxorubicin and cyclophosphamide AC with or without trastuzumab, and those who had already had an anthracycline got paclitaxel with or without trastuzumab. And that overall trial was positive. It was positive in both the anthracycline and the taxane arm, but the impact was actually greater in the anthracycline arm. The problem was that the cardiac toxicity was also very high, but we weren't screening patients as rigorously from a cardiac standpoint at the beginning of that trial. Now that we have better ways to screen patients that don't have cardiac problems, we have now learned that we can give anthracyclines and trastuzumab together, but we rarely do it in the clinic, again, because of concerns of cardiac toxicity. But there's been this lingering sense that maybe anthracyclines are a better partner, so that in the adjuvant setting, whether you give it concurrently or sequentially, that maybe anthracyclines are important. The big and important trial that tested that concept was the BCIRG-006, where they had a non-anthracycline arm combined with trastuzumab using docetaxel and carboplatin, and that actually showed equivalent results to the anthracycline plus trastuzumab arm. Numerically, there were more recurrences and deaths, but it was not statistically different. The trial was not designed to compare the non-anthracycline and anthracycline containing trastuzumab arms, so there's that lingering question. Now, there was a study presented at ASCO that looked at paclitaxel and FEC, 5-FU epirubicin and cyclophosphamide, where one arm, the trastuzumab overlapped with the epirubicin with the anthracycline, and the other arm it didn't. And the pathologic complete response rates in that neoadjuvant trial were equal, and the cardiac toxicity rate was low. So I think it's still an unsettled question, although I feel comfortable, at least with that study, that non-anthracycline therapy and the less cardiac toxicity that accompanies it is still a reasonable way to go, even in high-risk disease. I must say, sometimes I'm torn with really high-risk patients whether I should use an anthracycline-based regimen. Sometimes I do. So that's an important issue.